Professor, good evening. I would imagine that you must have been delighted to see those vaccines arrive on Monday. How's it going with the South African trials of AstraZeneca vaccines, which you've headed up?
So good evening, Sally. So the AstraZeneca vaccine trial, we hopefully will be releasing the results of that trial very soon, perhaps in the course of the next week. But as you also know that we have already reported from 2 other studies in South Africa now, the Novavax study, as well as the Johnson & Johnson vaccines. And the news from that has been reasonably positive. There were some concerns in terms of how well these vaccines are working against the variant that's currently circulating in South Africa. And the same thing probably will hold true for AstraZeneca vaccine as to whether it works well against the variant that's currently circulating in South Africa.
So I know that you've got many years of experience in vaccines. Tell us what you know about the AstraZeneca vaccine and how well it can protect us from the 501 YV2 variant.
So, in fact, today there was data released from the United Kingdom, which basically looked at the effectiveness of the vaccine against the variant that's circulating in the United Kingdom. And against that variant, it seemed to do pretty well. Obviously, the variant in South Africa is a bit more problematic in that it includes mutations involving very, very critical components of the spike protein against which the antibody acts. So I would be surprised, unfortunately, if the AstraZeneca vaccine or even many of the other vaccines work as well in South Africa relative to how well they've worked in countries where other variants were circulating that are more sensitive to the vaccine. So there is going to be some drop-off in terms of the efficacy of the vaccine, as we've already seen for the Novavax vaccine, and to some extent the Johnson & Johnson vaccine as well. Another important issue is in a Novavax study, what we also showed as an example in people that didn't get a vaccine, the individuals that were previously infected with the other virus that was circulating in the first wave, there was no difference against developing COVID-19 from this mutant virus compared to people that weren't previously infected, which means that past infection with a different type of variant didn't actually protect against the variant that's currently circulating in South Africa from reinfection, at least for mild and moderate illness.
Yeah. So you said that it should still work quite well. So explain what quite well means. If I get vaccinated today, and we know that the vaccine rollout is going to start from sort of middle February. Let's say someone gets vaccinated in the middle of February, and then they get exposed to the variant that's circulating here. Because they have the vaccine and they've developed the immunity through the vaccine, does that mean that they might get sick but only mildly? Does that mean they might die still? What does well enough actually mean in this particular context?
Yeah, so I think just a step back, what's important to recognize of all of the vaccines that are currently being authorized is all of them have been formulated based on a prototype virus. And like I said, there have been these sort of changes in the virus for critical components of the virus. What does it mean in terms of there's still some opportunity for it to work? It might well be that we need to recalibrate our expectations. The current generation of vaccines might not be what we require to get to herd immunity as quickly as possible, but at least what they would do is offer protection against severe disease. So we might well need to recalibrate our expectations of the current generation of COVID-19s because of the evolution of these mutants, which certainly are resistant to immunity conferred by past infection or immune responses induced by past infection. And there's also drop-off in terms of the effectiveness of immune response that are being generated by the current generation of vaccines. So there's going to be some drop-off in terms of efficacy, but I remain optimistic that they would at least still be able to protect against severe disease and moderate illness.
All right, so what I'm hearing from you is that it might delay us getting to that magical herd immunity, but it will definitely still prevent severe disease, which I think, that's not a bad deal, bearing in mind that we are looking at these new variants that are developing all the time. That's a real reality that we have to deal with. You've said to me before on this program that the AstraZeneca vaccine is the best for South Africa. It doesn't need to be stored at such extreme cold temperatures such as Moderna and Pfizer. Yet we seem to be going to import Moderna and Pfizer vaccines, which need to be stored at extremely cold temperatures. Do you think that we can handle the requirements of those particular vaccines?
Well, I think the Pfizer vaccine probably is a bit more problematic than a Moderna vaccine. I think the Moderna vaccine is one that we probably would be able to manage because it needs to be stored at a bit of a higher temperature at minus 20 degrees Celsius, and it does remain stable in room in temperature at about 2 to 8 degrees Celsius for a reasonable period of time. The Pfizer vaccine, I guess the Department of Health has done its homework in terms of what sort of facilities do exist in South Africa for us to be able to deploy a vaccine that needs to be stored at minus 70 degrees. So I assume the Department of Health has come to the conclusion to pursue these vaccines, both because they might be coming available, but also because there are plans in place to ensure that we don't lose these vaccines because of temperature deviations.
I have to ask you this as a final question. You have worked with many vaccination programs across South Africa for many, many years. This is a massive logistical project, bar none, I would say. From your assessment, what you're seeing so far, are the provinces and national government doing what they need to do in order to get these vaccines into people's arms?
Yeah, I think it's a really difficult question. I mean, every province can check all of the boxes that they prepared, but even what Germany is experiencing currently as an example, where they try to implement this registration system and appointment that are done electronically, they've been struggling in terms of getting those systems to work. So again, I think we need to be pragmatic in terms of what systems might be workable in South Africa, and the focus should be on making sure that we get as many people vaccinated as quickly, especially those at high risk, rather than becoming too sort of overambitious in terms of trying to introduce measures which won't necessarily lend itself to high coverage and would come at a huge cost.
Thank you so much for your time. I really appreciate it. Dr. Shabir Madhi heads up the Oxford Astrazeneca vaccine trials here in South Africa.